This Respiratory Physiology podcast addresses ventilation-perfusion ratios. Ventilation-perfusion scans clearly indicate that neither ventilation nor perfusion is distributed uniformly throughout the lung. The scans show areas of decreased perfusion, red arrow, and decreased ventilation, blue arrow. The scans also show areas of increased ventilation and increased perfusion. The most important aspect of ventilation and perfusion is how well they are matched. Problems will obviously occur if perfusion is increased in an area of decreased ventilation or vice versa. This presentation will focus on factors which determine the distribution of ventilation and perfusion. In addition, the matching of ventilation and perfusion will be discussed. One of the factors which influences the distribution of ventilation is LaPlace's law. Applied to the lung, LaPlace's law predicts that the pressure in an alveolus is related to the surface tension and the radius of the lung unit. This slide compares the pressures necessary to maintain two lung units open, one with a radius that is half of the other. Note that the units of measurement are irrelevant and that the pressure in the smaller alveolus is twice that in the larger one. This would obviously be extremely detrimental to lung function. Smaller lung units would become atelectatic, while larger lung units would tend to become overdistended. This illustration demonstrates the effect of LaPlace's law on lung units. As noted in the caption, the smaller lung unit would have a higher pressure, which would result in transfer of gas from the small alveolus to the larger one. The presence of surfactant in the lung changes the dynamic. Surfactant decreases surface tension. An example of this is that the surface tension of water is 70 dynes per centimeter, roughly 3 times the surface tension in the lung. Note that as the lung unit increases in size, the surfactant molecules become less concentrating, minimizing their impact. Conversely, surfactant molecules are packed closer together in smaller lung units, so their impact is increased. This is evident by the fact that at end exhalation, the surface tension in the lung is near zero. This illustration demonstrates that dependent lung units tend to have a smaller volume than non-dependent ones. This occurs at least in part because of the weight of the lung tissue compressing the lung units in the dependent areas. Due to surfactant, with spontaneous inspiration at normal inspiratory flow rates, which are about a half a liter per second, ventilation is preferentially distributed to dependent lung units. This results in a greater volume increase in the dependent lung units, noted by the greater increase in size after inspiration, blue lines. Ventilation is distributed essentially uniformly if inspiratory flow rates exceed about 1.5 liters per second. Inflation pressure, compliance, and airway resistance interact to determine the tidal volume, peak inspiratory pressure, and distribution of gas in the lung. This slide is complex, but shows what happens to ventilation to lung units as airway resistance and compliance change. The following slides consider each panel separately. In this and the subsequent similar diagrams, the x-axis is time and the y-axis is volume. This diagram indicates ventilation of two separate lung units, each with a normal airway resistance and normal compliance. Note that the time constant is the same for each lung unit. Remember that the time constant is the time necessary for inflation to 63% of the final volume if inflation were maintained indefinitely. The solid red line shows what happens to the top of the pair of the lung units. The dashed blue line shows what happens to the bottom of the pair of lung units. If gas flows were terminated and a constant pressure maintained, that is, if an inspiratory pause is applied through the ventilator. Because the pressures are identical in both lung units, there will be no redistribution of gas between the lung units. This diagram shows the consequences of a decrease in lung compliance accompanied by a simultaneous increase in resistance in the bottom lung unit. Note that the time constant for the bottom lung unit is unchanged. Note also that the bottom lung unit receives only half as much volume as the normal lung unit. Remember that the y-axis in this diagram is volume, not pressure. As with the situation of two normal lung units, under this circumstance, if an inspiratory pause is applied, there will be no redistribution of gas between the lung units because the pressures in both lung units are equal. The third diagram shows the consequences of doubling the resistance to the bottom lung unit. Secretions partially obstructing the airway would be an example of a condition that might produce a non-uniform increase in resistance to lung units. Note that the increase in resistance results in a doubling of the time constant for the affected lung unit. Also recognize that since pressure equals flow times resistance, the effects of an increase in airway resistance will be magnified with higher inspiratory gas flow rates, that is, with a shorter inspiratory time. One of the consequences of doubling the time constant is that the lung unit is still not completely full by the time the normal lung unit reaches its appropriate volume. As indicated by the black arrow, if gas flow is stopped at essentially any point during inspiration, gas will be redistributed from the normal lung unit to the one with increased resistance. As a consequence, applying an inspiratory pause or inflation hold on a ventilator will result in improved filling in lung units with increased resistance. Stated another way, there will be more uniform distribution of gas in the lung if an inspiratory pause is used in this circumstance. This diagram represents the consequences of an isolated decrease in compliance in the bottom lung unit. This results in a decreased time constant. That means this lung unit will reach its capacity, which is half of that of the normal lung unit, more rapidly. In this circumstance, application of an inspiratory pause would result in redistribution of gas from the lung unit with decreased compliance to the normal lung unit. The end result would be that application of an inflation hold or inspiratory pause would result in less uniform distribution of ventilation because gas will be redistributed from the smaller lung unit to the larger one. The fifth diagram shows the consequences of doubling the resistance in the top lung unit while decreasing the compliance of the bottom lung unit by 50%. These changes will result in widely differing time constants. The black arrows indicate that if an inspiratory pause is applied when the inspiratory time is short, gas will be redistributed to the lung units with increased resistance, resulting in improved gas distribution. On the other hand, the second black arrow indicates that application of an inspiratory pause after a long inspiration will result in gas redistribution away from the lung units with decreased compliance, resulting in less uniform distribution of ventilation. To summarize, if the time constants are equal, respiratory rate and duration of inspiration will have no impact on distribution of ventilation. Additionally, static and dynamic compliance will be essentially equal, and an inspiratory pause will not alter distribution of gas in the lung. These considerations change if the time constants of the two lung units are different. In that circumstance, respiratory rate and duration of inspiration will have an impact on the distribution of ventilation. Furthermore, dynamic compliance will be significantly less than static compliance. Stated another way, peak inspiratory pressure will be significantly higher than plateau pressure. Finally, Use of an inspiratory pause will result in improved distribution of ventilation in the lung. Now it's time to consider perfusion. Historically, blood flow in the lung was described as being gravitationally dependent. That is, blood flow was increased in the most dependent regions of the lung. This perfusion scan is of a healthy patient in an upright position. The scan is somewhat consistent with the hypothesis that the distribution of perfusion is dependent on gravity. You can see increased perfusion in the lower parts of the lung. Decreased perfusion is also evident at the apices. However, the gravity explanation is not consistent with the fact that there is obviously decreased perfusion at the very base of the lung. This graph is confirmation of that observation. It displays variation in perfusion per gram of lung tissue at differing lung volumes. The x-axis shows perfusion. The y-axis is the vertical distance above the most dependent portion of the lung. From this, it is evident that the most dependent parts of the lung have the least perfusion, obviously not at all consistent with the classic teaching that blood flow is gravitationally dependent. Nonetheless, it is still true that the areas with the greatest perfusion tend to be closer to the base than to the apex. It's not clear how much of the changes in perfusion may be attributed to gravity. Another frequently cited factor is branching of the pulmonary vessels, including differences in diameters between the two branches at the bifurcation points, and the fact that there is an increased number of pulmonary vessels at lung bases. Some researchers contend that as little as 25% of the regional variation in blood flow may be explained based on gravitational changes. Whatever the facts are, considering the impact of gravity on pulmonary perfusion is easily grasped and is a useful concept to understand the distribution of blood flow. Consider one example of the impact of gravitationally dependent perfusion. This illustration shows the effect of the lateral position on two-lung ventilation and perfusion during positive pressure ventilation. Notice that blood flow is preferentially distributed to the dependent lung, as evidenced by the fact that it receives 60% of blood flow. Lung units in the dependent lung are smaller and therefore have more densely packed surfactant, resulting in increased compliance compared to lung units in the non-dependent lung. The end result is that both ventilation and perfusion are preferentially distributed to the dependent lung. Ventilation, because surfactant tends to overcome the decreased compliance that would occur due to compression of the lung tissue. Perfusion, because of the impact of gravity. This culminates in a shunt fraction of only 10%. This illustration contrasts what occurs with one lung and two lung ventilation in the lateral position. Note that no ventilation goes to the non-dependent lung. Note also that blood flow to the dependent lung is increased. Although the shunt fraction is over 25%, acceptable oxygenation may still be achieved. Consider what would occur if gravity played no role in lung perfusion. In that circumstance, ventilation would be limited to the dependent lung, while perfusion was equal throughout both lungs, resulting in a 50% shunt fraction. In a very real way, one lung ventilation is only possible because of the fact that perfusion is preferentially distributed to the dependent lung. When contemplating ventilation-perfusion matching, the lung can be considered to constitute 5 different types of lung units. Perfect alveoli, where ventilation and perfusion are perfectly matched, producing a VQ ratio of 1. Dead space lung units occur where there is ventilation in the absence of perfusion and the VQ ratio is infinite. This occurs with a pulmonary embolism. Because there is no perfusion of these lung units, the ventilation entering these areas does not contribute to the elimination of carbon dioxide. If minute ventilation were constant, an increase in dead space would result in hypercarbia. Between a normal lung unit and a dead space lung unit, some alveoli may have ventilation in excess of perfusion. These lung units would have a VQ ratio greater than 1 but less than infinity. At the opposite extreme from dead space are absolute shunt lung units. These lung units have perfusion but no ventilation, and the VQ ratio is 0. This would occur in the situation of atelectasis. Because there is no ventilation of these lung units, it is not possible to add oxygen in the blood perfusing them, so some hypoxemia will occur as a result of a shunt. Between a normal lung unit and an absolute shunt lung unit, some alveoli may have perfusion in excess of ventilation. These lung units would have a VQ ratio greater than 0 but less than 1 and will contribute to the development of hypoxemia. Now I have to get on my soapbox. Personally, I despise the phrase VQ mismatch. All that says is that ventilation and perfusion are not matched appropriately. Accordingly, all 4 of the types of ventilation and perfusion mismatching shown in this slide, that is, a relative shunt, an absolute shunt, relative dead space, and dead space, are all examples of VQ mismatch. Using that phrase says absolutely nothing about the type of problem that exists. It's as if a PACU nurse came to you and said, "There's something wrong with the patient's blood pressure." Based on that statement alone, you don't know if the patient is hypertensive or hypotensive. The same thing applies to the phrase VQ mismatch. You don't know if the problem is areas of high VQ ratio or low VQ ratio. Most people who use the phrase VQ mismatch use it to describe this type of lung unit. I believe reference to this type of lung unit should use accurate terms, either relative shunt or the more precise terms areas with a VQ ratio of more than 0 but less than 1, or areas with a low but finite VQ ratio. Now I'll step back down off my soapbox and describe how ventilation and blood flow are matched in the lung. This graph represents the changes in both ventilation and perfusion throughout the lung. Notice that, as previously described, both ventilation and perfusion are greatest at the base and least at the apex. Arguably, the most interesting part of this graph is the yellow line, which represents the VQ ratio. Notice that at the base of the lung, perfusion, indicated by the red line, exceeds ventilation, indicated by the blue line. This results in a VQ ratio that is less than 1. The situation is reversed towards the apex of the lung, where ventilation exceeds perfusion. This results in a VQ ratio of greater than 1. At the very top of the lung, there is no perfusion, but ventilation persists, resulting in a VQ ratio that approaches infinity. These lung units represent dead space. Finally, consideration needs to be given to graphs obtained using the multiple inert gas technique. This is capable of displaying the VQ ratios of lung units. Notice that the x-axis represents VQ ratios, while the y-axis represents ventilation, blue line, or blood flow, red line. Note that almost all of both the ventilation and perfusion are tightly centered around a VQ ratio of 1. There is no absolute shunt, that is, areas with a VQ ratio of 0. And there is no dead space, that is, a VQ ratio equal to infinity. This graph represents a patient with asthma. Notice that there has been an increase in areas of relative shunt, that is, areas with a low but finite VQ ratio. This is a graph for a patient with ARDS. The most noticeable changes about this graph are the dramatic increase in blood flow through areas of relative shunt and the appearance of areas of absolute shunt, that is, blood perfusing alveoli that are not receiving any ventilation. The final graph displays VQ ratios in the conditions of a relatively small pulmonary embolism. The most obvious change on this graph is the dramatic increase in the areas with very high VQ ratios. If there had been a larger pulmonary embolism that had completely occluded one of the pulmonary arteries, there would have been a significant number of lung units that had an infinite VQ ratio. These would have appeared as a dot on the far right side of the graph. Additionally, there may well have been lung units with low but finite VQ ratios, that is, relative shunt, as all the blood flow was diverted to one lung, while ventilation initially continued unchanged to both lungs. In conclusion, both ventilation and perfusion are subjected to forces which result in non-uniform distribution in the lung. Atelectasis would be more common in the absence of surfactant. Surfactant is critical to minimizing differences in the distribution of ventilation. Airway resistance and lung compliance affect distribution of ventilation. It is useful to consider the distribution of perfusion as being primarily influenced by gravity. VQ ratios describe the relationship between ventilation and perfusion. Finally, VQ ratios are helpful in understanding the pathophysiology of pulmonary disease. Thank you for your attention. I hope this presentation has been educational.